Thank you, ladies and gentlemen, for joining our e-seminar presentation today, Concussion Management, Background Research, and Rehabilitation Strategies. Our speaker today is Dr. Jason Mihalik. This presentation will provide important concussion-related background with an emphasis on peer-reviewed literature. Management strategies including, but not limited to, return to practice or return to participation and concussion rehabilitation will be presented. Dr. Mihalik is a Keenan Jr. Faculty Fellow, Assistant Professor in the Department of Exercise and Sports Medicine. He is the co-director of the Matthew Gfeller Sport-Related Traumatic Brain Injury Research Center and currently serves as the director of the EXSS Cadaver Anatomy Laboratory. Dr. Mihalik teaches courses in biomechanics and undergraduate research methods. He also assists with graduate statistics and research methods. Dr. Mihalik completed his undergraduate degree in exercise science with a specialization in athletic therapy at Concordia University in Montreal in 2001. He completed his graduate work in sports medicine at the University of Pittsburgh, earning his master's degree in December of 2004. He was the recipient of a 5-year Royster Fellowship, allowing him to ultimately complete his doctoral work at the University of North Carolina at Chapel Hill in the summer of 2009. He currently serves on the board of directors for the Canadian Athletic Therapists Association. Dr. Mihalik, welcome and thank you for sharing your expertise with our audience today. The presentation is now yours.
Thank you, Teresa, for that introduction, and thanks to everyone for signing up for the webinar. I was contacted by Natus Medical several months ago and asked to be a speaker for this online webinar, and I quickly accepted the offer as an opportunity of perhaps a unique and creative way of getting some of the information from the work that we've been doing here at UNC and that some of my colleagues abroad have been working on to the masses, and hopefully many of you will leave this morning with newfound knowledge and some information and some additional tools to throw in your toolbox as you're dealing with these athletes that are suffering from concussion. So it's no surprise that traumatic brain injury is a very multifaceted condition. There are a lot of things that we know about traumatic brain injury only because we've been able to observe athletes or patients that have suffered from it. So things like cognition, we know that cognitive skills or cognitive function has declined following traumatic brain injury because we've observed those instances in individuals that have suffered from TBI or concussion. Some data have suggested that individuals with a concussion history, a history of injury, of brain injury, are more likely to sustain subsequent concussions, and those subsequent concussions are more likely to take longer to recover. We know that balance or postural stability is affected by traumatic brain injury. And there's a lot of things that we've learned about how we perform a physical exam. What are the questions to ask? What are the things to look for? So the whole notion of physical exam has also been enhanced, again, unfortunately, because we've been able to refine those skills in managing individuals that have suffered from head injury. We know that athletes suffering from traumatic brain injury are symptomatic, and that symptomatology can range from very mild symptoms that last only a very short period of time to more severe symptoms that may last for a longer or prolonged period of time. We know that things like knowledge and attitudes and behaviors of athletes and coaches doesn't necessarily influence their willingness to report that they've suffered a concussion. I'll talk a little bit about that later on. You know, and of all these pieces, really the only one that has a huge role in injury prevention, again, as I've been describing these different facets of TBI, what we've learned is the result of injury, and the mechanism of injury piece is one in which the more that we learn from that, the more we can change behaviors on the field. We can enforce rule changes and policy changes that will hopefully prevent some, but not all, of the concussions that are sustained on the field. Another piece that people haven't really spoken about all that much is that of treatment. The standard of care for concussion management for a long time, and still remains, is a wait-and-see approach to managing the injury. Most of us, I think, who have managed concussions or young athletes that are suffering from concussion have approached it in very much the same way. We've kind of put that patient on cognitive and physical rest until such time as their symptoms have resolved or gotten better. And so rest is the cornerstone of our interventions with athletes that have suffered from concussion. And while the rest is important in that acute phase of recovery, there comes a time where rest is no longer an issue in the sense that even though they're still symptomatic 2, 3, 4 weeks, 2, 3, 4 months down the road, at some point we can't leave someone in a black, darkened closet for all that period of time. We start to see manifestations of a lot of symptoms that are consistent with concussion that now start to be linked more with the psychological aspects of being away from their team or being away from their sport or not being allowed to compete. That social reintegration issues that we see with a lot of our patients. And so this whole notion of treatment is something that is relatively novel. And when I say treatment, I'm not necessarily just saying wait and see if their symptoms will resolve, but what are things that we can do with patients whose symptoms don't resolve in a predictable fashion, those who are persistent for several weeks post-injury. What can we do with them that's different to hopefully get them back to activity? And I say activity because it's not necessarily return to play, it's return to practice, it's return to the classroom and so forth. When we look at the number of publications that are providing evidence towards concussion management, what you're seeing here essentially is in the first decade of the 2000s, there were more publications in that 10-year span than the 40 years before that. So there's a sudden surge of public awareness. There's a sudden surge of medical professionals who are faced with these injuries, who are at an impasse at times on how to manage them appropriately. And so we see a concomitant increase in the amount of research that's being done. And the far right column, which is the current decade we're in, we're only 2 years into it or 3 years into it. And the numbers here are a little dated, but we're already almost surpassing the halfway point of the entire last decade before. And so clearly there is an increase in the amount of publications that are being put out there in the field of sport concussion. But again, our standard of care hasn't really changed all that much in the last 8 or 9 years. We're still at this wait and see approach until the athlete gets better. One of the most important guidelines to concussion management is that no athlete returns to participation while they're still symptomatic. And this, again, is not necessarily return to competition, but it's returning to practice. It's returning to the classroom. There are things that we need to consider there as well if someone is still very symptomatic, of then burdening their brain with exercise, with what I like to refer to as cognitive exertion by having them sit in the classroom. Importantly, symptoms are subjective. So, athletes will lie, cheat, and steal to get back into play. I was an athlete myself, and at one time, I'm sure I did that to get back in. So only relying on athletes reporting how they feel is probably not the best way to go about managing concussion. In fact, about 40% of athletes that reported no symptoms were still showing signs of neurocognitive deficits. The next section that I'd like to take a few minutes on is just kind of dispel some myths. I know there's a wide range of attendees on this webinar, ranging from physicians to athletic trainers to physical therapists to parents to athletes themselves. And so I just want to take this opportunity to spend about 5 minutes or so and dispel some of the myths that are out there regarding concussion and concussion management, and then progress from there into more of our discussion on the concussion rehab piece. So the very first thing is, how should I refer to the injury? And we've all heard this, I just had my bell rung, I don't have a concussion, I just got dinged. Well, the reality is concussions, however minor they may be, are injuries to the brain. And bell ringers or dings are mild forms of brain injury and really shouldn't be dismissed. And some work by Mark Lovell and his colleagues at the University of Pittsburgh Medical Center, almost a decade ago, identified that those athletes who were sustaining ding or grade 1 injuries resulted in neurocognitive deficits that were still present and measurable almost 2 days post-injury. So even milder forms of head injury really shouldn't be dismissed, and they really shouldn't be referred to as a bell ringer or a ding injury, but really as a concussion, or better yet, as a brain injury. when we talk about discrepancies in concussion reporting, a lot of it has to do with the nomenclature that we use. Tamara Valovich-McLeod out of A.T. Still University about 4 or 5 years ago, reported, it was a retrospective look of athletes, and she asked these athletes to report how many of them had sustained a concussion in the academic school year prior to the time they received that survey, and you can see that less than 10% reported having a concussion. And one of the follow-up questions, she asked how many of them sustained a bell ringer, and you can see that this number increased to 25%. It's almost a threefold increase in the number of individuals that had sustained, presumably, some mild form of brain injury that weren't really referring to it as a brain injury. And so you can see here how a lot of these cases can be mismanaged or underreported, and how that might affect the long-term outcome for that patient. In a follow-up study that was done here at UNC Chapel Hill by Dr. John Mahalik, again, we can see the blue bar has increased considerably, so almost a threefold increase in the number of athletes that reported concussion, and a lot of things could explain that over the last 4 or 5 years with media exposure and public awareness of the injury and so on and so forth. But we also still see this almost 50% increase in the number of individuals that sustained a bell ringer that didn't refer to that injury as a concussion. And so I think we as a medical profession need to enforce the change in nomenclature, make it standard practice to refer to these as brain injuries, and correct people when they use terms like bell ringer and ding injuries. So why is education important? Well, from a clinical standpoint, educating our patients is one of our primary functions. And the reason is over 50% of concussions may go unreported. And in some of our research here at UNC, we're finding that this may be actually over 75 to 80% of injuries. So for every 2 concussions that we identify, or that an athlete comes to us on the sideline and says, I just don't feel right, can you take a look at me? There's probably 8 others that are being underreported. And if you can't identify the injury, then you can't evaluate them and you can't manage them properly. And by identifying the injury at the onset, we could start young athletes on the right path to recovery. And many individuals play a role in the athlete behaviors concerning concussion. It's the clinical network that doesn't just start at the emergency room door, but it involves coaches and parents and players and officials on the field and league officials and administrators. And then we obviously play a very important role there as medical professionals. Second impact syndrome is a condition that does occur, however rare, and the clinical definition of second impact syndrome, essentially, it usually results in the athlete dying, and they usually die when an athlete sustains a second head injury before symptoms from a first head injury have fully resolved. And again, I say that it's a rare condition because it's only been diagnosed in upwards of about 50 or 55 athletes. But from a clinical spectrum standpoint, obviously death is the worst case scenario in these kids, but we see a wide continuum of what second impact syndrome can do to a young athlete. It's not uncommon for us to evaluate a high school kid 3, 4, 5 weeks after their second impact, who are now getting C's and D's when they were otherwise getting A's and B's in the classroom. And so while they didn't die, the long-term implications of that injury, of that second impact to their ability to go to college and earn a degree and find a career and be good contributors to society can sometimes be impacted by these secondary impacts. Another myth, and something that I've heard frequently, and some of you I'm sure have heard as well, is my child had an MRI in the emergency room and everything looked fine, so they don't have a concussion. And the reality is the current imaging techniques that are used in most clinical settings today are designed to identify structural abnormalities. And they do a really good job of that, of identifying cerebral brain bleeds, of identifying skull fractures, the things that will kill an individual. Concussions don't kill athletes. It's the mismanagement or the underreporting of those concussions that could have the long-term catastrophic outcomes. So concussion is a functional abnormality, and it will return a negative finding on standard imaging most of the time. And so there are other techniques that are designed to identify functional abnormalities, things like diffusion tensor imaging, susceptible weighted imaging, functional MRI, and a lot of these are being used kind of in the research realm right now, but are still several years, in my opinion, away from having widespread clinical application for concussion in the emergency setting. Another myth is that concussion has to be the result of a loss of consciousness, and the reality is that more than 85% of diagnosed concussions result in no reported loss of consciousness. And so this notion that, oh, my kid didn't black out, they don't have a concussion, is really something that we need to educate out of parents and coaches and athletes themselves, and medical professionals for that matter. Another hot topic area is that of equipment and how equipment can help to prevent concussion. And one piece of equipment that is out there is that of mouth guards. And really, when you look at the research, there's very little, if anything, that supports mouth guard as a concussion preventing tool. There's really a lack of evidence when you investigate all of that. However, that being said, I would like to emphasize that mouth guards are effective in reducing things like maxillofacial or dental trauma, and really should be worn for that reason. And as long as parents know that and are aware that that is its primary purpose, and they're not duped, or they don't buy a $400 mouth guard because they think it's going to reduce concussion, then I think we're going to be better for that. When we talk about the reality of concussion in youth sports, there's a considerable resource and knowledge shortage. There are teams of medical professionals that are surrounding our elite athletes, our professional athletes. Even if you look at the college setting, just the number of athletic trainers and team physicians that are on the sideline of a football game is remarkable. But when you look at the actual number of concussions that occur at the professional level compared to what's occurring at the youth level, there's this really disproportionate resource and knowledge shortage, and that people who are handling young kids, coaches and parents and the athletes themselves, they really don't have a lot of medical personnel that are there. Sometimes the team doc is the coach, and it's up to the coach to identify these injuries, and not 3 athletic trainers and 2 team physicians on the sideline of a game. And so while there's very strong medical presence and really good education and knowledge at the elite levels, there really isn't those things at the youth levels. Yet there's a far greater number of concussions occurring at that youth level. Another myth is that, quote unquote, my kid passed a concussion test. And this is where I'm going to get on my soapbox for a few seconds and say clinicians should really think about relying on their clinical skills, looking at things like balance testing, looking at neurocognitive testing, and using those as special tests. I use the analogy of an ACL injury. By the time you're done with your history taking and your observation of that athlete, you've got a pretty good idea that it's an anterior cruciate ligament tear. You might do a Lockman as a special test, or you might send them for an MRI to confirm it, but you've got a pretty good idea that that's going to be an ACL tear. And the same should be true with concussion. You shouldn't just hear the words, I got hit in my head and I have a headache, and sit them in front of a computer and let the test tell you what to do. There are some instances where neurocognitive function is not impaired following concussion, but balance is, or symptoms are present. There are instances where symptoms are not present, but neurocognitive function still persists. So really, there's a number of tools that exist, and those tools are just that. They're special tests that should help you inform your clinical diagnosis, but really, at the end of the day, you should rely on your clinical skills. If the kid just doesn't feel right, or you don't think the data are telling you the right things, then trust your gut. You're a clinician. You're well trained to make those decisions. Another myth is, my star player shouldn't miss the next game because he or she has a concussion. The reality is that concussions are brain injuries, and brain injuries, just like any other injuries, need time to heal. And one way to do that is cognitive and physical rest. So it's not just refraining them from activity, but sometimes it's the consideration that you might want to restrict academic exposure, whether it's they stay home from school for a couple of days and they get eased in for a couple half days. And again, that will depend on your clinical evaluation, how symptomatic the athlete is, and what type of symptoms or complaints or exacerbations that they are reporting to you. So now that we've gone through some of the myths surrounding concussion, I want to focus a little bit on the rehabilitation piece. And this section I do want to emphasize is not necessarily evidence-based. I will talk about a little bit of research that has been done in this area, but I want to kind of push the boundaries and have people think creatively about some of the things that they can do with their patients that are complaining of persistent symptoms. And the first question that comes up is do I rest my athletes or do I not rest my athletes? And really it's an important question in the context of concussion rehabilitation. So in a study that I was part of out of University of Pittsburgh Medical Center when I was a graduate student there, we retrospectively reviewed charts for 95 concussed student athletes, and they were categorized into 5 different groups of post-injury exertion. On the one end, we had athletes that did not go to school and did not exercise, or they didn't go back to their sport. We had other individuals who went back to school activity, meaning classes, but they did not return to their sport. In the third group, we had school activity, and we may have had light activity at home, things like mowing the lawn or slow jogging, things like that, although I would admit that mowing the lawn can sometimes be quite an arduous and exertion task. Our fourth group went to school and returned to practice, and our last group went to school and actually returned to play as well. And we performed neuropsychological testing and symptom status. Essentially those data were analyzed across these 5 groups. And what we found is that the highest level of activity following the concussion, perhaps no surprise to us, resulted in the worst outcomes. So those that went back to school, those that went back to play following their concussion, had the worst outcomes. And I do want to emphasize here that this was not a prospective study, meaning we did not randomize individuals into these groups. It was a retrospective look, and based on the things that they reported to us in their clinical evaluation, we categorized them based on their post-injury exertion. Intermediate levels of activity, interestingly, had the best outcomes. Now, I should also emphasize that all 5 groups showed impairments relative to pre-injury baseline scores, but that middle group, the group that went back to school activity and some light level of activity, actually had the best of the worst outcomes, if you want to put it that way. And interestingly, the group that had absolute rest, that was restrained from school and restrained from sport activity, actually had worse outcomes than the intermediate levels. And so it kind of begged the question, is there some way that we can control and monitor and very closely a light level of activity that might promote a better outcome for our patients? So is there potential for timed exertion or rehabilitation strategies? And certainly this is an area for future research and one in which people are currently pursuing. I would also like to emphasize the caveat that those folks who are restrained from school or restricted from school and sport activity are likely those that had very obvious symptoms, very obvious mechanisms of injury. The diagnosis of concussion was probably very easy to make, and so the decision was to withhold them from everything. On the flip side, the athletes who went back to activity are likely those who either didn't report their symptoms at the time or did report them and they were very, very mild, and the clinicians felt it was okay for them to go back, obviously in hindsight, in error. And then that return is what catalyzed some of the issues that they came to the clinic to see us about in the future. There had been some proposed return to play guidelines. I personally don't like the idea of calling it return to play because it eliminates the notion that there's practice, there's participation, there's activity, there's cognitive and physical activity. So I would personally categorize this, if you're going to create your own handouts for your patients, kind of categorize this as return to activity guidelines. And the one that's included in the Zurich consensus statement from 2009, and there will be another one coming out in March, so about a month from now, from the most recent Zurich meetings that were held in 2012, you could see on the left-hand side the different rehabilitation stages. It starts with no activity, and the functional exercise, or the reason for that, is to allow recovery. It's to allow recovery through complete physical and cognitive rest. From there, when the athlete feels better, we could progress them to light aerobic exercise. And again, there's some examples here of functional exercises. But if someone's not a swimmer, then maybe swimming is not the exercise that you use for that individual. So certainly it's going to be on a per patient basis that you customize some of these return to activity guidelines. But the focus here is to increase the heart rate. You want to see if by increasing the heart rate, you see an exacerbation in symptoms. If they still remain asymptomatic, symptom-free, then the next step would be to progress them to sport-specific exercises. So if they're an ice hockey player, for example, you might have them skate, again, avoiding all contact. If it's soccer, you might have them do running drills, but again, no head impact activities. And the functional component, or the objective of this stage, is to add movement to the athlete. So they're not just stationary, you're not just increasing heart rate, but you're also including a facet of motor control. If the athlete remains symptom-free following this stage, then you would progress them to non-contact training drills. And this is where you progress them to more complex sport-specific drills, like passing drills in football or hockey, or they may start a progressive resistance training exercise. Again, each of these steps is very closely monitored by someone that you trust to do that, whether that's yourself or you delegate that responsibility to another professional. And the objective of that stage is obviously to get them back into shape, right? We want to get them conditioned. We want to functionally rehabilitate these individuals so that when they return to play, they are at the level they were at, if not better than they were before. So things like improving exercise intensity and level, improving coordination, improving cognitive load, having people think while they're moving is an important context in sport, and certainly something that should be addressed in any rehabilitation protocol. From there, you would progress to a full contact practice, and this is only following full medical clearance to participate in normal training activities. You don't want to go from a non-contact training drill session to a return to competition. There needs to be some exposure to the threats of an actual physical competition, and so you want them in a scenario where they are in a tackled practice, they are in a practice where they body check or where they head a soccer ball and so forth. And the objective here is primarily to restore confidence and to really assess the functional skills by the coaching staff to see if that athlete is ready to return. Just because someone is cleared medically does not mean that a coach will return them to play as well. And so there's some communications there that have to take place. Ultimately, if they're able to progress through this and they're still symptom-free, then the final stage is a return to play or a return to full activity, and that's normal gameplay. Now, this focuses on the athlete. Again, the Zurich guidelines is the concussion in sports, and so their guidelines have been based primarily on an athlete returning to competition. But the high school athlete or the college athlete has a lot of those kids go to classes because they're student athletes, student coming first, then some of this also has to carry over into other activities that they do. So maybe they got injured in football, but they're riding their bike, or they're playing baseball with their friends, or they're going to physical education class, and that physical education class is doing basketball that block for some reason. So there's other things beyond simply what sport did you get hurt and how do I get you back to that sport. There's other things in the life of a young non-professional athlete that need to be considered as well. And the average healing time is in the 7 to 10 day range. It's a little bit longer in the high school athlete. And so really you would begin this return to play progression once you have determined that the athlete is asymptomatic, so when they're symptom-free, and when they have cleared on other measures that you use to help you inform your diagnosis of concussion. So essentially, when you have cleared them of their concussive event, that is when this 4 or 5 day progression begins. So if that athlete is asymptomatic 2 days post-injury, they could progress through these steps and return 7 days after their injury. If it takes them 7 or 8 days to recover from their injury, then it might be 12, 13, 14 days before they get back on the field. I mentioned the student athlete, and another component to rehab really is to help manage functional academic deficits. And someone's not going to come in and say, you know what, doc, today I really had a hard time with memory consolidation. I really had a hard time retrieving things. That's really not the, this column of neuropsychological deficits isn't really what the athlete is going to report to you, but what they might report to you are some of these functional school problems. Like, I had a really hard time focusing on the lecture today. It was a 50-minute class, and, by about the 20-minute point, I really started to lose focus. Or, the teacher gave us some instructions for homework. I didn't write them down, and I had a hard time remembering it. I had to talk to my friend to remind me what the homework was. So you'll be or the athlete hopefully will be reporting, or you're going to be asking questions that will address some of these functional school problems. And then the right-hand column is essentially some management strategies, right? If there's a short focus on lecture or class work or homework, maybe one of the accommodations that are made in the acute phase of that athlete's recovery is to assign shorter assignments, or to break down the tasks in smaller, more completable chunks, so to speak, or give them a lighter workload for a couple of days. If holding instructions in mind, or reading comprehension or math calculation, is an issue where normally they would do things with, mental math, and that's really hard for them, then maybe they use a calculator in these initial days following following concussion, or they read shorter passages, or they write their instructions. So there's a lot of strategies that you can employ, and this certainly is not anywhere near an exhaustive list, but having people in your medical team to help control or to make sure the athlete goes through their recovery in a very well monitored and controlled fashion is very important. And sometimes this won't be part of your medical clinic. It might be contacting the school counselor, the school nurse, or someone in the school, or the teachers themselves, to identify some of these functional school problems and propose some of these management strategies for the athletes. The next question is whether we can rehabilitate concussions, and quite frankly, there's very little research in an athletic mild traumatic brain injury population, but ultimately the end goal of any rehabilitation program, and one specifically for concussion, is to not only improve, but to also maintain physical ability, cognitive ability, and visual focus ability. Anecdotally speaking, the majority of the athletes that I see and that I help through some of these customized rehab programs that have symptoms that persist for a while, for the most part, have identified some type of visual influence to their symptoms, and whether that's a complaint of blurred vision, whether it's a complaint of something as abstract as the room is spinning around me, or they feel like they're on a boat effect where the room is bobbing up and down all the time. We see a lot of athletes that have visual problems that really manifest some of the long-term issues that they are experiencing. And so it's not only addressing and improving physical ability or cognitive ability or visual focus ability, but it's really doing all of those together, the ability to perform all of these together. And there have been some proposed management strategies, and I'll go on and discuss some of those. So Cicerone, a couple of years ago, stated in one of their publications that there's substantial evidence to support interventions for attention, memory, social communication skills, executive function, and for comprehensive, holistic neuropsychologic rehabilitation after traumatic brain injury. And so this is very global, very comprehensive approach to it. And you're not only focusing on some of the attentive tasks, but you're also working on the memory. You're working on their ability to socially reintegrate with their peers. You're looking at decision making, executive function. You're also looking at the kind of the cognitive rehab piece. So it's not just one thing. It's not like an ankle injury where you could rehabilitate, proprioception and balance and strength. It's far more complex than that because it's the brain, it's the human computer, and how do you reboot that computer and rewire things in the short term to get the processors working at full capacity again. In pilot studies in military personnel with traumatic brain injury, cognitive strategy training has been shown to improve compensatory mechanisms and increase cognitive functioning. So there appears to be some role that's based on the military model that suggests that cognitive rehab allows them to exploit the neuroplasticity, essentially, of kind of rewiring and working around some of the impaired areas to still achieve an outcome of interest. Divided attention. So training divided attention, or what is commonly referred to in the literature as dual task strategies, can lead to transfer to real life activities involving dual tasking. And so things like being able to maintain balance while performing a cognitive task is something that is very portable and very translatable to sport, right? Athletes have to move. They have to, stand on one leg and change directions while looking at a play and interpreting what that means, where they need to be, where the ball is going to be, where their opponents are, and so forth. Working memory is a component of most activities and tasks. Think of play calling, and you have a wide receiver who's suffering from concussion and memory issues, and they had a team meeting that day to go over plays. If that athlete doesn't remember the play, they don't affect their performance well. So there's specific training that could lead to working memory improvements, and we've seen this in patients with severe traumatic brain injury, but we really haven't explored it in the milder realm, which is where we see concussion. I mentioned the typical recovery course of being around that 7 to 10 day window, and what you're seeing here is a number of studies that we've done. The first column represents NCAA football players. The second column is a concussion prevention initiative, which was a study that was done here out of UNC, looking primarily at high school athletes. And then a study by Mike McRae and his colleagues in Wisconsin, looking at this high school Project Sideline study. And what you can see here is that there is as the ages go lower and lower, so going from the NCAA, which is all college, to CPI, which is college and high school, to the high school project, which obviously is all high school, you can see that there is a much lower percentage of athletes, presumably the younger athletes, that do recover in less than 7 days. And if you look at the prolonged or the real prolonged recovery, which is right under the red line on your screen, you'll see that in college athletes, we see about 10% of the athletes that have symptoms that prolong beyond 10 days or beyond 7 days, sorry. But we see as many as almost 20% of high school athletes having symptoms persisting beyond a week. And those that persist beyond one month, we see a very small number of our college sample, but we see 5%, which is 1 in 20, which is a considerable number in the grand scheme of the number of concussions that occur at the high school level of athletes that are complaining of symptoms persisting beyond 1 month. The neurometabolic cascade, which is really the thing that has driven the fear of second impact syndrome, is this kind of metabolic mismatch, and the brain is in disarray. When it gets struck again and it's disorganized, it causes, you know, this immediate diffuse swelling that causes second impact or the death outcome. You know, it's something really that hasn't happened beyond the 7 to 10 day window. So once you get past that, if an athlete is still symptomatic, I'm not suggesting you send them back to an impact scenario, but I think it's safe at that point to start to explore, again, under well-monitored and controlled environments, that ability to kind of exercise and to exploit some of those things, especially if as many as 20% of people are going to complain of symptoms beyond 1 week to a month. So let's talk about the treatment and novel interventions and strategies that we've used here. And again, the whole purpose of this isn't to etch in stone an actual rehab protocol, but it's to get you thinking about the different tools that we've used. Think about the types of patients that you work with, and then think of ways that you can apply some of this to your patients to elicit improvements. I mentioned dual tasking already. And you know, part of the dual tasking is kind of tying into different technologies. I'm going to talk a bit about that. So one of the questions that we've asked ourselves is, can we use technology to assess and rehabilitate concussion? Well, we're very fortunate here at UNC to have one of the best virtual environments research groups in the country. And so, you know, the theory is that virtual reality environments could provide a mechanism to stimulate our athlete, but not endanger them. So for instance, if we're trying to rehabilitate a football player, we might be able to immerse them in a virtual environment with other football players, yet the risk of them sustaining an actual head impact is slim to none. And so we can measure just how ready they are to return to competition without actually putting them in there and crossing our fingers and hoping that they don't get hurt again. There's different types of virtual reality that exist, and the purpose of this talk is not to really focus on the different technologies that are available, but I do want to emphasize that the one we used was a head mount display, so not different from kind of an older style night vision goggle. What you can see here is this little strobe here that I'm circling on the screen communicates with sensors that are stripped on the ceiling above that person, and so it allows the computer rendering in the goggles, which is this part of it, to turn and rotate and change and come closer and go further based on how this sensor here is communicating with their position in the actual physical environment. And so we did a test. We did the balance error scoring system, which might be familiar to many of you. It consists of 6 different stances. There's double leg. You can see here double leg. You can see single leg, where they're standing on their non-dominant limb, and tandem. And they repeated on a foam surface as well. The brown block that you see the individual standing on is a force plate, which is really just a research geek's really expensive weight scale. And we integrated the balance testing with the force plate so we could look at things like center of pressure and so forth. And so we wanted to replicate a balanced environment using this, what we felt was a top-heavy virtual reality system, and identify whether or not the visual interpretation or the actual equipment itself would throw someone's balance off, right? If you throw 5 pounds that's front heavy on someone's head, there's a very good chance that it'll affect balance. And what they saw in their system when they opened their eyes, which is an error as scored by the balance error scoring system, but when they opened their eyes, they saw this rendering, and this rendering was an exact replica of the physical environment around them. You can see the brown block here that I'm circling here on the screen. You know, that's very similar to the block that they were standing on. It's textured as well. I'm not sure if the resolution on your screens can identify that, but certainly it was a replica of what they had in their virtual or their real environment, because if they opened their eyes, we wanted them to see something that was similar to their real environment so they wouldn't fall over, 1, and injure themselves, 2, damage some pretty expensive equipment. And then we threw in some rendering of the balance error scoring system foam pad, the ARX pad. And the main finding is that the weight of the head mount display doesn't affect balance. And so our next steps here moving forward are to now integrate other aspects of virtual environment. The military does this as part of their training. We're looking to integrate some of that as part of their rehabilitation as well. And you can see here just another example of the virtual rendering, which is on your left-hand side. You can see the squared area that shows you this little plank that I've circled on screen. And then you can see the patient or the participant in the actual environment wearing the head mount display. And they're on a physical plank that is about 1 inch off the ground. And so as they inch their foot forward and forward, they feel that they're actually on a board, and it stimulates all the physiologic responses that someone would have standing 20 feet above an object. Things like increased heart rate, blood pressure, sweat rate, and other physiological responses. So it's a really neat way of really creating virtual and reality or real environments in essentially a virtual context. Another thing that we've used is the Nintendo Wii Fit, and there was a video there. Oh, apologize for skipping forward there. There was a video there where we used the soccer heading game of the Nintendo Wii Fit. For those of you who have used that system, you know what game I'm talking about. But essentially, it's an individual who stands on the Wii Fit platform, which is a very inexpensive force plate. And they control the head of the computer, or the head of the character on the computer screen, by shifting their balance back and forth, left and right. It's not that they move their head, it's that they shift their body. And so now it's a notion of using balance, using someone's ability to control balance, and also to react to a visual stimuli. So the stimuli that present to this computer rendering on the screen is soccer balls coming at you. And obviously soccer balls are the things that you want to head in the game. And so you would shift your balance to move the head of the character on the screen to head the soccer balls. But then there's also distractors, and there's mild distractors. And it might sound silly because the mild distractor is a panda head. Well, the panda head is black and white, just like the soccer balls. And so it forces the patient to not only look at the stimuli and say, black and white, could be a ball, could be a panda head, it's a panda head, I need to avoid it, as opposed to saying, black and white, could be a soccer ball, could be a panda head, it's a soccer ball, I have to move to hit it. So you can see that the instructions are very different. And so it's this learning that you're also instilling as part of this rehabilitation. And then the obvious distractors are soccer cleats that come at you. And so obviously, you want to shift and avoid those. And there is a scoring system. There's a point system involved with the game. And so you could, to a certain extent, use that scoring system as some outcome measure, some quantifiable number to say, hey, last time you did this, you scored 38 points. Let's see if you can get 50 points today. And use that as part of your rehabilitation strategy. I haven't found an athlete that isn't compliant to playing video games as part of their rehab. So it's certainly a tool that's worth investigating further. There's a lot of talk recently about hyperbarics as a potential intervention. We currently have a randomized clinical trial ongoing here at the University of North Carolina that we're about to start, really. And it has been shown to improve cognitive performance in some cases. Animal literature suggests that there's positive effects of hyperbaric oxygen therapy on cognitive function following TBI. Again, that's animal literature. What does that mean to humans when we test them? We don't know, and that's what the focus of this randomized clinical trial is. But it's something that does exist. It's something that will be discussed with you by parents and patients who are exploring some other options, especially in those that are taking a much longer period of time to recover. There's other things that we could do to train sensory performance. So this again is a video that isn't playing, but what you would see in these glasses that the goalie is wearing is that they're what we call stroboscopic glasses, meaning that they flicker on and off. They go opaque and transparent, and you could control not only the frequency of that transition between opaque and transparent, but you can also control whether it's only one eye or only the other or both, or whether they go at different frequencies. And what it does is it allows the patient or allows the athlete to see a visual stimuli, to see the ball coming towards them, for example, and then it eliminates that information for a very brief period of time or longer if you change the settings. And so when the vision then reappears, when the opaqueness of the glasses go away and they can now see through the glasses, they have a much shorter period of time to react to a stimuli. Obviously, this is not the first step to your concussion rehabilitation program, but it's certainly something in the long term that you could use to help enhance that reaction to objects or to things that could cause injury. And it's certainly something that we're exploring here at the University of North Carolina. Obviously, there's some widespread military applications to traumatic brain injury. Many of you might be involved in the military realm. So it's not only things like, are they getting better, but when you think about the military, they don't have the luxury of saying, time out, insurgents, go back to where you were, we're going to come back over here, we're going to send our medic, no one shoot anymore. They don't have that luxury. Football, the referee blows the whistle, people go back to their sideline, it's a controlled environment, they have all the time to make the decision, they can remove an athlete, evaluate them in the locker room. That luxury does not exist. That person who sustains a brain injury in theater still has to perform a duty, or his or her comrades to the right or left of him or her may die if they aren't able to deliver. And so there's still this added element, even in the military, of let's get this person through whatever this activity is and get them back to a forward operating base where they can be evaluated in more detail, which is something that is very unique and very different from the athlete. There's also entrepreneuring lab work into public safety. I've had the pleasure of co-authoring a number of smartphone applications. One is the concussion recognition and response app, and the target user for this is parents and coaches. And the goal with this app is to provide them a systematic way of walking through a suspected head injury and to inform them of essentially the referral path. So to identify, was there a mechanism? Does the athlete have symptoms? Do you observe signs? And it walks them through it. It's not some video that they watched 8 months earlier and you're hoping that they'll remember the 22 symptoms to go through, but it's all provided to them at their fingertips. They can then email it to the school's athletic trainer to say, hey, Sarah just got hurt at soccer practice. Can you come take a look at her? Here's what I found. It could be sending that information to the parent to say, this is just, what happened to Johnny at baseball practice. You probably need to take him to the physician and so forth. The other application to the right is the concussion assessment and response app, and the target user there is for medical providers. And this is where we have not only a symptom list, but we have the severity of the symptoms. So kind of using that Likert, that 0 to 6 point scale that's commonly used in graded symptom checklists, so that you could track symptoms. You can use the balanced error scoring system. It's scripted, it's timed, everything is in there. There's the standardized assessment of concussions built into there. So there's a number of tools that are available to you to be able to measure and track recovery in your athletes. So how can we improve the long-term outcome for these patients? Well, we first need to identify a problem, and I think we've all collectively done that. The media has done. I have some opinions with their methods, but they have certainly done a good job of putting concussion at the forefront of the conversation when it comes to sports safety. So there is a problem. The problem now that we've been talking about today, isn't necessarily concussion itself, but it's what do we do with the athlete who doesn't recover typically on their own in 7 to 10 days? What are some other things that we could do with them? So that's the problem. We certainly inquired. We're exploring different types of dual task mechanisms. We're looking at virtual reality training. We're looking at visual sensory performance training and so forth. And that's really promoting a lot of curiosity, not only on my part and that of my colleagues, but also the clinicians. And certainly you all being a part of this webinar today is testament to that. Then there's the whole notion of experimentation, right? We need to provide evidence. It's not just consensus that is going to result in changing outcome for our athletes. It's not a bunch of experts that sit around the table and say, well, we do this, so we think everyone should do this. And while that's fine to start the conversation, we really need to be doing some strong prospective research studies to provide the evidence base to physicians and athletic trainers and athletic therapists in Canada and physical therapists and other allied health professionals that are mandated with caring for these athletes. And hopefully we'll get some answers, and those answers won't come quickly, unfortunately. And I'm not naive to think the answers we get to this first round of inquiry will be the final. Those answers certainly will stem more questions and more problems that we'll want to address to continue improving the outcome for our young athletes.
Dr. Mihalik, thank you so much for sharing that very thorough and detailed presentation. This will conclude the recording of today's presentation.